Urology was one of the first to pick it up, and I think because it was a procedure that was easily done, or one of the procedures that was easily done and made sense to do it robotically was prostatectomies. Prostate surgery is a pelvic surgery, just like gynecologic surgery is a pelvic surgery. It's deep down in a sort of a space that's very difficult to see. The robot allowed us to suddenly see much better, allowed for magnification of the area. We're operating in a 2 by 2 inch space. That's where the robot really helps out tremendously. So I think it was just natural that urologists picked this up for prostate surgery and then started to use it for other things like kidney surgery and bladder surgery as time went on, as we got more and more comfortable with it. And we're starting to see the same thing with the gynecologists as well. There's a drop-off in terms of of who's actually doing the surgeries because we're starting to get more and more specialized. We've looked at studies now, or we've looked at actually the demographics as well as who's actually doing these procedures. There's a regionalization of care, meaning that in New York State, as a urologist or as a patient, you're going to seek out your care in larger centers, tertiary care centers. You're going to go less and less to sort of your community center or community hospital. And thus it's going to be sort of these centers of excellence that are starting to pop up now. And there's really a regionalization of care where most of the sort of large inpatient volume is going to go to large centers. Inpatient volume in general is dropping off tremendously in most hospitals, and we're starting to see sort of a closure of all these larger hospitals becoming much smaller, becoming ambulatory or day surgery type of procedure, day surgery type of facilities. I think that's one thing that definitely needs to be addressed here. So what are we doing here? We're starting to funnel care to facilities that can offer these procedures safely and efficiently and can get patients home quickly. So that then it becomes, how do we make sure there's access for patients to get this type of care? Well, that's going to be the second part of this is yes, we've maybe figured out it's probably better to go to a large facility that does a lot of these, but at the same time we need to make sure that our patients can come to see us and can get the care at those kind of places. Even in New York State, we're starting to see this, what we call a regionalization of care, meaning that only certain hospitals are really starting to become players in this technology and in the ability to deliver the health care that makes sense. Whereas 10 years ago, it was sort of keeping up with the Joneses. Every hospital had to buy a Da Vinci system, had to sort of park it, had to find a surgeon to do it. We're seeing less and less of that, and simply because there's a cost prohibitiveness behind it. Not every hospital can afford to keep up with the latest technology. Da Vinci has also increased or has changed the generation of each instruments that they've been using. Sort of every 10 years we get a new, or 5 to 7 years we get a new sort of Da Vinci robot. They're literally on their 4th one right now. And so to keep up with that, I mean, you have to remember each of these instruments cost anywhere from $1.5 to $2 million, plus there's a certain charge per year for maintenance, and each of the instruments themselves cost money. So you really, if you're going to invest the time and effort into delivering the healthcare with a robotic technology, you also have to have the financial capabilities for it as well. So I think that most training programs have introduced robotic surgery and have made it sort of a commonplace. Certainly certain fields like urology have done so. Gynecology is making this part of their normal training. Again, as the technology gets cheaper, as training programs become more and more comfortable in teaching surgeons how to do it, I think you'll see that it's going to be sort of a commonplace procedure in most institutions, in most disciplines. We're actually in urology having the trouble now that we almost have to go backwards and teach our residents how to do open surgery again because they're not getting exposed to that. Laparoscopic surgery even is on the decline because most of these things are being done robotically. So again, it's a training issue and also a sort of an evolution in how surgical procedures are being done. So I think robotic surgery needs to get cheaper. It needs to get wireless. It needs to get smaller. The ability to do these procedures in a true telemedicine fashion is really the future. So meaning that not that I'm operating, you potentially can operate on someone anywhere in the world and have the ability to do so safely and efficiently, where there's a comfort level with the surgeon and the patient knowing that they're going to get top-notch care. I don't think it's so far-fetched even in our lifetimes here to certainly, go on the internet and look for a surgeon in Taiwan, for instance, who's going to take out your gallbladder. I don't see that being such a far-fetched concept. And we'll be able to rate surgeons about how well they do or how well hospitals or surgery centers are doing or are delivering the care that they're supposed to be delivering. So, I mean, I think there's a whole new world as to how we're going to be delivering care and how we're going to be rating ourselves, not only the surgeons, but also where patients are going to be looking for their care.